hands, the amount of nail varnish, jewellery, long nails I saw was incredible, especially when these were care staff working with elderly with frail skin. I'm surprised they didn't have more skin tears. And I have to say that to get the message across, it was really important to tell them why these things aren't acceptable. And once they understood the reason, they were a lot better about it. Waste storage was always a bit of a problem. Some places just had somewhere where they stashed it out the back and thought that was all right. Laundries and sluices. There are care homes out there where the laundry is the same room as the sluice. My worst experience was walking into a laundry room on a Monday morning to find a load of red bags flung on the floor, one of which had split open and the contents were leaning, and this is gospel truth, on a pile of oven gloves and tea towels for the kitchen. And I pointed this out to the laundry woman, and she said, "Oh, don't worry, I'll give them an extra rinse." And I thought, okay, we've got a problem here. But it is that kind of attitude. People think that there is no problem with disposing of faecal matter and urine in a room that's also used for clean laundry storage. So that was it was an eye-opener, I can tell you, but we got there. Some of these care homes, it quickly became apparent, didn't have policies. Or if they did, there were policies that had been around an awfully long time. So I offered a policy checking service, for want of a better word. I'd come in and I'd look through their policies. It quickly became apparent that a lot of policies needed a lot of work where they existed. So what was done was I created a generic set of policies that the care homes were welcome to use and adapt for themselves so that they would have up-to-date policies available for them. Now, although I was working with the care homes, I was actually employed by the PCT, and we did have a whole system approach. The generic policies were based on PCT policies, and the training materials on PCT training materials, and that way there was no conflict of interest when, for example, a district nurse went into a residential home to perform some action. It all joined up and worked. All the policies and training materials were passed by the Infection Control Working Group, and the Health Protection Agency nurse for our county also reviewed them. So we were all working together with the idea that we were all getting the same message across, which is really important. Because we used the same training materials, it meant that I could train PCT staff if needed. I shared an office with the PCT infection control specialist, who I think is lurking here somewhere. Mohammed, are you here? There he is in the corner, which was really useful because we could inform each other about what was going on in the community, what was going on in the hospital, and we could keep an eye on what was happening. It was also really useful if there was an outbreak somewhere that we could just let each other know what was going on. So that worked really well. In order to get more buy-in from the homes, I decided to create something called a Cleaner, Safer Care Home scheme. This was open to all homes with more than 20 residents because we had to limit the number of homes in the scheme. There was only me and there was a limit to the number of homes I could get to. It was free to enter, 2 levels of certification, and these homes were also offered the chance to send a member of staff on a Train the Trainer course and again to have agency training for the staff that they used there. For the lower level certificate, they had to have an identified infection control link nurse, provide adequate infection control training for new staff, yearly updates for existing staff, and have an environmental audit. And for those areas where they weren't up to scratch, had to produce an action plan for it. For the whole certificate, they had to do everything for the participation certificate, but also achieve complete compliance with the audits, and also to utilise and show an improvement in infection control using the Essential Steps tools. So it was actually quite a lot of work that they had to put in to get it. But I have to say, I was so proud of the homes. Some of them really, really committed to this and did so much work on it. It was fantastic. 20 of the 40 eligible homes expressed serious interest, and 9 homes actually managed to complete the higher level of certification. which did involve an awful lot of work from them. 4 tried to get to the higher level and didn't quite make it, but they did get the participatory certificate, and 7 worked towards it, but weren't able to reach the criteria. I was actually quite strict with them about it, I'm afraid. So, overall, about the average homes made about an 18% improvement score on their audits, and their essential steps tools also showed improvements too. I'm not sure if you can see that here. It might be clearer on your handouts, but it's the percentage increase in scores there for what they did. And that was all down to their hard work in doing that. They were fantastic. So, was the project a success? Did we reduce infections in the care homes? Well, this is CDI cases. You can see the white arrow shows when the project started. So, yes to the CDI and yes to the MRSA, although in truth the numbers were quite small. And that's it. Thank you very much.